Welcome, welcome, everybody. Thank you for joining us for today's episode of Connected Conversations, a reason for hope, the evolution of obesity science and where we are coming from and where we are going. Our guest today is Dr. Mary Forhan, and we will introduce her in more detail. And I'm super excited for everybody to be able to meet. I'm just going to call you Mary, not Dr. Forhan today. So let's get started. For those of you who may not have joined a Connected Conversation before, this is our monthly series that is brought to you by Obesity Canada. In these conversations, we really try and discuss and dig into the important topics for people living with obesity and also the experts in the field, from advocating for access to evidence-based treatments, issues related to diet culture, weight bias and discrimination, to innovating obesity care in Canada. Connected Conversation works to address the complexity of this chronic disease and the barriers that those of us living with obesity face almost on a daily basis. So my name, for anyone who doesn't know me yet, my name is Lisa Schaefer. I am a patient advocate. I'm a proud member of this patient community. Professionally, I'm a marketer out here in Vancouver, and it has been my absolute pleasure for the last 5 years to volunteer and serve Obesity Canada on the Public Engagement Committee. I work really hard to work with Dr. Ian Patton, who will introduce himself in a moment as well, on advocacy efforts, really trying to make the voice louder of those of us in the patient community and really try and change the conversation and understanding of this disease that is really highly stigmatized and really misunderstood and often misrepresented. So my brother in arms, as I was saying, is Ian. So Ian, I'll let you introduce yourself for a second as well.
Sure, thanks for that, Lisa. So for those of you that don't know me, my name is Ian Patton. I'm the Director of Advocacy and Public Engagement with Obesity Canada. My background and training is in kinesiology, that I actually did some research and training in obesity research as a graduate student. But I'm also someone who lives with obesity. I have a lived experience and like Lisa have over the last several years become a bit of a patient advocate. And that's kind of the area that I focus in. A lot of my work now is in that patient advocacy and engagement. And and so that's what I do with Obesity Canada. And I'm always excited about being here on these connected conversations. And this one in particular is one I'm really excited about with Dr. Forhan. For a little bit of housekeeping, if you are familiar with Zoom, down on the menu on the bottom, if you scroll your mouse over the bottom there, you'll see there's a bit of a menu on the bottom. There's a couple features that we can raise your attention to. There is the chat feature. You can use that to keep the conversation going, kind of add your thoughts and input and communicate with each other if you want through that chat. I would encourage you all to introduce yourself and let us know where you're coming from. And then if you have questions for Dr. Forhan or for Lisa and I, you can also use the Q&A feature. So if you click on that, you can type in your questions through there. Within that, you can also upvote questions. So if you see someone has written a question that is similar to one that you wanted to ask, you can always give it a thumbs up and that'll bump it up towards the top and you don't have to duplicate the question over and over again. So do that and use that if you have questions. As always, we generally do not have time to cover all of the questions that come through the Q&A or through the chat. I'll monitor it and I'll try and make sure we get to as many as possible. But that doesn't mean, we won't get to those questions in some form. So there's other ways we can address those questions. We do keep a record of them. And it's something, if it's important, we can definitely get to it afterwards and answer those questions. So feel free to use that, ask away any questions you might have. And I'll leave it at that.
That's amazing. And those questions, as Ian was saying, we may not address in real time on this call, but we may address it in the connected community later. And it also is a great impetus for Ian and I to understand the kind of conversations you guys are looking to have as well. So it might inspire us for future opportunities. So please do use the chat or use the Q&A function. It really does help us. But let's tuck into today and a reason for hope. One of the best things on the face of the earth right now. I think we all could use more and more reasons of hope, but let's focus it in today on the evolution of obesity science, where we're coming from and where we are going. As I said, our guest today is Dr. Mary Forhan. Mary Forhan PhD is an associate professor and chair of the Department of Occupational Science and Occupational Therapy at the University of Toronto. Dr. Forhan is a health researcher who applies occupational and rehab science, a rehab science lens to research focus on bariatric care and rehabilitation, with the goal of reducing the disability experienced by persons living with obesity, improving the quality of care patients with obesity receive, and reducing the burden of obesity on the healthcare system. She is the scientific director here at Obesity Canada, yay, and also the vice president, Association of Occupational Therapists University Programs. So welcome, Dr. Forhan. Yay.
Thanks, Lisa and Ian.
Amazing.
It's so good to be here. So good.
We're pumped to have you. You know, we had a former scientific director that was quite vocal and a lot of people knew, and Dr. Arya Sharma, and I don't think near enough people know about you yet. So let's pump your tires a bit and get you a little more in the spotlight. Ian and I are super excited for this conversation, and it really does feel like a great opportunity for our audience to better understand what's going on, particularly here in Canada, when it relates to obesity research. And I think that's a great lens that you'll be able to bring. One of the things we need to acknowledge right off the top is how broad of a range of topics could fall under that area of science of obesity, that really there's a lot to talk in there. And I think many people may think about very common topics or those narrow focuses that we know are actually kind of almost stigmatizing to us, in and around like physical activity or nutrition, or perhaps specific treatments like clinical trials and medications or bariatric surgery. But we really know that obesity science is so much more than that. And we certainly do not have the ability to cover all of these things in 1 hour today, although you and I can accomplish a lot in an hour, Mary. I know I've seen it. But we'll try and touch on some of those important areas today. But before we tuck into all of that, I'd love for you to introduce yourself a little bit more. Tell us a little bit more about yourself, about your role as the scientific director here at Obesity Canada, and kind of what led your interest into working in this field.
Yeah, thanks, Lisa and Ian. It's been a journey, I'll tell you. And like many things I embark on in life, pretty much everything, there was no plan. It just kind of unfolded, and roads opened up and opportunities. And there's a really great quote from a scholar, and it's in a book called The Last Lecture. And if you haven't read it, it's an easy read. It's an emotional read, and it talks about luck being when preparation meets opportunity. And that's kind of how I describe sort of the career path that I've had. It's been quite lucky, actually. So I started my career as an occupational therapist in 1990. And so it's been a while. And I was working with individuals with chronic disease. I was working in hospitals, in the community, all kinds of different areas. I was working in psychiatry, in eating disorders, meeting incredible people from adolescence to late adulthood was really the populations I was working with. And I started, particularly when I started working in the area of eating disorders, this issue of weight management, was coming up, and this focus on body size and body shape. And this would have been in the early 90s. And I was really hearing these stories of people waiting to live their lives, like waiting until, like, oh, I'll do that when I achieve my ideal weight. I'll do that when I'm at a healthy weight. And I'm just like, what are we waiting for? Because whenever we're dealing with anything that is a chronic type of health condition, it's chronic. It's going to take a long time. We shouldn't be putting our lives hold in the midst of living with any kind of chronic disease, including obesity. And so I actually was really lucky. Again, luck is when, opportunity meets preparation. And I always tell my students and anybody else, never underestimate just these little things that happen and where they can lead. So I was working at an eating disorders clinic in Ontario, and I was the phone for the clinic was, or actually it was an outpatient day hospital for psychiatry. And I was one of the case managers there, and the phone was ringing, the receptionist was away. So I thought, I'll just pick up the phone and say, hello, it's Mary from so-and-so clinic. And it was an endocrinologist in the community who was wanting to hire a behavioral therapist for a new obesity management clinic that he was opening up. And I said, well, why do you want a behavior therapist? This is what this poor man got from me answering the phone. And he started to describe it. I said, I think actually what you are looking for is an occupational therapist. It's like, what is that? I said, do you have time for a coffee? We'll chat. Well, long story short, I ended up meeting with this endocrinologist, convinced him he needed an occupational therapy a therapist to work at this obesity management clinic, one of the first of its kind that opened up. And I ended up working there as a consultant for 10 years. So picking up the phone, selling, marketing, Lisa, right?
Yeah.
There's an opportunity. And it was the first time an occupational therapist had been formally in a role in an obesity management program. And I was able to take all those skills that I had from working in chronic disease management, from working in mental health, from working in an eating disorders program, and the eating disorders program I worked in was really helping people become healthy, regardless of body weight, was getting people healthy and being able to get back to their daily lives. And so I took all of that knowledge and skills and theories and applied them in the area of obesity. And it just got me so excited. But I needed more. And so I was a clinician, I was an occupational therapist. I was not trained as a researcher at that point. And so I started having more clinical questions than I had answers for. What is that lived experience of people living with obesity? I was in such a privileged position to have patients and clients share really serious and intimate details of their daily lives. And I thought more people need to hear this and understand this. And keep in mind, this was in the 90s. This was before the movement around patient engagement and lived experience was respected. This was where it would be clinicians or scientists raising or speaking on behalf of patients, which we do not do anymore. So talk about an improvement in science, right? We've really started to move away from that, which is fantastic. But at that time, that mechanism was not in place. So I had an opportunity to do a PhD. And I thought, you know what? I think I will, because this will give me the skills and ability to be able to answer those clinical questions and raise the voice of obesity in a rigorous research way. So I did that from 2006 to 2010. I was a full-time PhD student at McMaster University, and I looked at the lived experience of what it was like to live with severe obesity. So that I was looking at, and I know we don't use BMI like we did, but back then we did, for people living with a BMI of 40 or more, because that was a voice and experience that was not in the research documents at the time. And so that just went from there. And another coincidence on how I happened to get involved with Obesity Canada is it involved another phone call. So I was working as a research assistant at McMaster University in probably about 2005, just before I started my PhD. And I read a headline in a newspaper back when you used to read a newspaper, on paper.
Ink
and
on
it
your
said,
fingers.
yeah, it was dirty fingers and everything. I think it was the Hamilton Spectator. And they were announcing the arrival of this incredible doctor, Dr. Arya Sharma, was coming to Canada, and he was going to be working in Hamilton, and he was interested in obesity research. I'm like, are you kidding me? This is what I've been waiting for. So I picked up the phone and phoned the area that he was said that he would be in, and he picked up the phone and we started talking. He says, where are you? I said, well, I'm just up the street. I'm at another clinic. He goes, well, why don't you come by 4:00? I'm writing a grant for the Canadian Obesity Network. So I went and met Arya Sharma. This would have been 2004 in his little office in Hamilton. I think it was Hamilton General. And he says, what do you do? I said, I'm an occupational therapist. Started talking to him. He puts me in his office chair, like literally, if you've met Arya Sharma, he's not like a quiet wallflower. He goes, here, sit in my desk chair. And he pushed me into the desk. It was on wheels, and said, type 3 sentences about occupational therapy, physical therapy, rehab science for this grant. And that was when the funding came through for what is now known as Obesity Canada. And I got to get rehab science on in there, from me picking up the phone, Arya Sharma answering the phone, and here we are. So my career in obesity really started with, unexpected phone calls and just being at the right place at the right time and taking a risk. So I think I love when those things come together. I didn't plan any of it at all. So here we are. And I've been, working in an area of obesity research since about 2006. And my interest has really been about better understanding that lived experience. And then from that, from the generosity of people sharing their stories with me, is being able to see where some of the gaps are that I feel rehab science has been able to have some impact, which is the built environment, where people live, work, rest, and play, and how a larger body is able to interact with that space, and how weight, bias, and stigma may be a barrier. How we bring in industrial design to create more open, accessible spaces. That's science. That's research. And I think we often don't think about that when we think about obesity research. We think about the physiology, the pharmacology, all really, really important pieces. But we can't have comprehensive approaches to helping people with obesity live their best lives if we don't include other aspects of where people live, right? And what happens outside the body. And so that's really been the journey. And I've had, a professional relationship with Arya Sharma since that time I met him in 2004, and have been part of Obesity Canada since its inception, as much like you, Ian, as a trainee, as a student, as a new professional, and it's been a part of my professional career ever since. So I'm just super stoked on how that all happened.
That's such a great and powerful story. I love it so much. And what I love is that you're kind of drinking your own champagne, is the way we say it at my office as well. In as much as, like you were saying, why are people waiting? You need to show up now. And you showed up in each of those phone calls and shared your experience in your life and your hopes and dreams. And that is something that resonates very much for me. I've been saying it to Ian ad nauseum for at least 5 years now. Like, I just want people to show up for their own lives. I don't care what your body looks like. I want everybody to know, like, take up space, get in the room. Let's figure this out.
Yeah.
Sorry, Ian. I know you were going to talk. I'll let you.
No, go ahead. Mary,
no, that's all.
No, go ahead, Ian.
Oh, okay. No, I was just, I started chuckling a little bit when you're telling your story about Arya. I think for those of us who know Arya or Dr. Sharma, many of us probably have similar experiences with him that have kind of shaped where and what we're doing now. So I definitely have that experience myself. I don't think, I guess many of our audience members, they might not know this, but we actually, Obesity Canada, like you kind of alluded to, Mary, we started as more of a research network. It wasn't a charity organization. The charity stuff happened later on, 2015, I believe we got our charity status, or something like that. But we were originally the Canadian Obesity Network, and it was a research network designed to kind of bring people together from all these different areas. And I think it was really important. And I think one of the great aspects of having you on as a scientific director now is also recognizing that there are these diverse areas of obesity research. It's a very broad kind of umbrella, right? And when we talk about obesity science, a lot of people think of those, whether it's basic science or talking about nutrition and molecules and, the hormonal stuff that goes on with the medications and stuff, but it is way, way more in depth than that. There's so much more going on. And for several years early on, Obesity Canada, or the Canadian Obesity Network, ran a training program. I think that was one of the things that was a real focus of the organization, was to train the next generation of academics and health professionals. And so this training program that ran was called the Canadian Obesity Summer Boot Camp. And so I myself was one of the trainees that went through that boot camp, and I can tell you it was transformative for me as someone who went through it. I was going through as a kinesiologist, like I mentioned. I was looking at childhood physical activity, more specifically school-based physical activity for kids. And I can tell you, going into that experience at boot camp, I honestly thought that what I was working on was going to be world-changing. I was going to change the world because we were going to get kids active in schools. We were going to utilize that time that they had there a little bit more efficiently. And all of a sudden, the obesity problem is gone. I was very, very naive and didn't understand the complexity of it. But going to boot camp and experience, having those interactions with Arya and all the other faculty members that were there, I came away from there kind of mind blown about how much more there is to this and all the different areas and how small of a piece to the puzzle my work was. And that was really important. So Dr. Forhan, you were also a boot camper. You went the year before me for that. And so there's a bit of an alumni group of people. We all recognize each other and talk about that. But did you have a similar experience? And what were some of the topics that you experienced in that boot camp or in that training that kind of shaped or changed your direction?
Yeah, no, thanks for bringing that up, Ian. I think that we called it summer research, obesity summer research school later on, because boot camp scared some people. We actually didn't do much. We sat a lot. It was a very sedentary camp because we were in class. It was true school. What was really impressed me with that, I did that, I think, after 1 year of my PhD program. So I'd had some exposure sort of to the rehabilitation science PhD that I was working on. And much like you, I thought, well, part of me was like, well, I don't belong here because what I do isn't science, right? It's not classified as science. I would never have said I was a scientist. Now I say it with pride. But before it was like, maybe what I'm doing is more just social interest, something people need to be aware of. But I didn't think about it as science until I got there. And then you start seeing I was meeting researchers or other trainees from universities across Canada, and there was some international delegates there as well. I'm not sure, I can't remember where everybody was from, but I know later on we had a real partnership with the university in Germany. And I was listening to the diversity from molecular level, genetic science that I'd never been exposed to as a scientist. That's not the type of science that I do. But we were all forced to learn from each other. And when I say forced, it was really uncomfortable. The first couple of days, it was a 7 to 10 day school. And we needed to listen to other people's research. And then we had to review research articles that were completely outside of our field. And I remember having to read one about mice and vitamin D, and I had to learn all about the methodology of that. And then I had to write a critical reflection. So criticize this research paper in an area I knew nothing about in front of the senior scientist. It was Angelo Tremblay's article. For those of you who know Angelo Tremblay, I was terrified because I was presenting his paper and criticizing it. But what it did was it really forced us to learn about other people's areas. And then somebody had to criticize my area of research, but it allowed us to educate each other. So now when I'm working with other team members, interprofessional collaborations, I can work with a scientist who is working in the labs on animal models and that real basic science that feeds into the other work that we do, that we can work together and really respect each other's area and recognize that one is not more valuable than the other. And as you said so nicely, Ian, it's a contribution to the bigger picture of having this comprehensive approach to living with obesity, on what are new and novel pharmacotherapies that might be coming up, to better understand how obesity is expressed differently in different people based on their molecular makeup and their genetics. As an occupational therapist coming in, I never would have been talking like that. That just wasn't my experience. That's not a requirement to be an occupational therapist. But now I can sit around the table and have enough of an understanding to not do that science, but to understand and respect that science and have it as a consideration in the spectrum of science that we do. So, from someone talking about these fine models of animal research that is so important in the area of science, to the science that I might be talking about on how to design the best bathroom in a long-term care facility that someone in a larger body can access safely and effectively and independently. We all are valued at the table. And I think it's just really incredible to see it happen. So I think that boot camp, we have to find a way. I have to tell you, maybe I'm saying something I shouldn't online here, but we are working really hard to find a way to bring that back, using today's technology and recognizing that our world has gotten so much bigger with technology, that we can do that. So stay tuned. We are going to build capacity for scientists coming up the pipeline. And I wouldn't have met Ian otherwise, right? And I think, Ian, you and I ended up teaching at a boot camp eventually, right? Like you do get called back as faculty. So what Obesity Canada is so amazing at doing is building capacity of researchers, clinicians, volunteers, people who want to be part of this so that we can advance the science not just, and people think, oh, you're only doing science to get rid of obesity. You just want to get rid of obesity. That's not what we're about at all. We're about, helping promote best lives, right? And meeting people where they are at. And it's not about weight. It's about health and well-being. And individuals from the research that we've done have told us what well-being means for them. And now we've been able to translate that research to physicians to say, you need to listen to what your patient is telling you, because that's the outcome that's important, not the bottom line at the other end. And the physicians have listened, they have listened and they have changed their practice based on the evidence that we had from that lived experience. So we make sure that we have that feedback loop that impacts not just treatment at a medication side, but bedside manner, professional relationships, patient physician relationships, having multidisciplinary teams at the table. Your background, Ian, is kinesiology, right? We need to have kinesiology in the background as part of the team. We have to have occupational therapy there as part of the team. We have to have physical therapy. We have to have social work. We have to have nursing. We have to have psychology and psychiatry and industrial designers, and all of that is important. Policymakers, public health professionals.
Yeah. And you're touching on a couple of the questions I was going to bring into this kind of going forward here. I guess we'll do this one first. Thinking about obesity science, it is relatively a young area of science in comparison to other ones. And I often hear, other doctors and stuff that we work with talk about obesity being kind of where we were 15, 20 years ago in terms of diabetes, for example. And so it's interesting to see how rapidly and how quick things can change for other disease states and stuff like that, and kind of recognizing where we are. And I feel like with all the advancements that, what happened with the clinical practice guidelines, the change in the definition that we go with now as far as obesity, there's a ton of talk about and research into weight bias and discrimination and that angle of things. There's all these new areas and things that are popping up and becoming more and more important and prevalent, but you still also have advancements in things like medications that we talked about with Dr. Sue, or treatment options and things like that. So it's rapidly growing. And especially over the last 15 to 20 years. So maybe can you talk a little bit about how the field of obesity science has changed over the course of your career?
Oh, absolutely. I think, and again, I started working as a clinician in the area of obesity at what was then called a weight management clinic, but it was really an obesity treatment. And it was really about the medications available were not effective, and they were actually really high risk. Like, this is going back to days where there was, I remember, I'm not a doctor, so I'm not going to be fully accurate in my names of everything, but we used to refer to it as fen-phen, and I remember it had severe complications that were unbeknownst to anybody, that would, the physicians at the time, with really severe lung damage from that. And so, just in terms of the safety of approaches to obesity management. And even as early as when I started, we were still seeing people using things like stimulants to, suppress appetite that is, historically from days of drug use, and in terms of really dangerous addictive kinds of substances. So the safety of what we're seeing from a pharmacotherapy perspective. And, I think that is the science informing the complexity of what we're talking about. This isn't just a behavioral issue. This isn't about just stopping somebody from eating. And so when we address weight bias and when we address obesity as a complex chronic disease, I think it really does broaden the opportunity for real investigation into what are the multi-pronged approaches that are best and how can we personalize those. So I think the safety of obesity treatment has improved significantly. And that's also from the surgical interventions as well. Any kind of surgery is risk. There's risk associated with any kinds of medical interventions. But I think the gastric surgeries that we would see in the 90s to what we're seeing now are night and day. And again, I'm not a surgeon, so I'm not going to go into detail because I won't do it justice. But just to see, and when I first started working in obesity management space, I was against surgery. I was like, oh, no way. That is not an option. That is, an easy way out. Please, quote me in context with that because I don't believe that to be the case now. I don't want that soundbite coming out that I said it's not. I have grown to really respect, and again, from my training, from my exposure to people doing research in bariatric surgery and learning from the surgeons that do this and meeting with people who have had it, have grown to really see the value of that as a viable option for people, and to get rid of that judgment or those preconceived values that I would have had as a clinician on that being an option that patients need to talk about and work through decisions around. So I've seen this growth in the safety, the options, the personalization. And I think one of the biggest things I've seen is the respect for looking at the patient's life beyond the office or beyond the hospital bedside. Is where is this person wanting to go and need to do? What are the things that they need to be able to do in the context of living with obesity? And I used to use this phrase living while losing. And that was when, we were focused on weight loss. We don't do that as much anymore, right? There's weight loss involved sometimes, but that's not always the end goal. So it's living in the context of managing your obesity. And that's where I see the research really expanding into looking at mental health, looking at psychology, looking at other things, like even about, access to equipment that people can safely use while they're being more active, while they're mobilizing in the community. When I first started doing my research, I was approaching manufacturers of walkers and wheelchairs and rollators and hospital beds and crutches and all those things to say the weight capacity of the equipment that I have available to me to recommend for my patients will not support their body weight. And what I used to hear back is, well, I guess they need to lose weight then to be able to use our equipment. And I'm like, no, how about you work with me and let's make that equipment and let's make it nice looking. Let's make it not just look like a big piece of heavy equipment. Let's make it beautiful. Let's make it things that people want to use and interface with so that they will be safer going about their day-to-day lives. In fact, if we provide the right mobility equipment, some of the patients I was working with could actually go back to work or go back to their recreational activities or go back and socialize the way they used to, whatever it might be that brings them pleasure. So it has taken 20 years for what we refer to as bariatric equipment to actually be part of the mainstream market. That did not exist. And it's so much easier now for those working in that area, for patients seeking equipment, that it's there. It's no longer custom, because it used to be custom and that made it so expensive that it wasn't even accessible. And now it's covered by insurance companies. It's covered by some disability pension funds across various provinces in Canada. So that did not exist 24 years ago. And now we have a long way to go, but it's better. So, Ian, I could go on, but this is where I've seen sort of the growth since I started my career. And I never thought it would happen, but it is finally. I just wish that I had been more persistent as a younger self. This is, what would you tell your younger self? I would have said I should have worked like harder to get one of those companies to build the equipment. They didn't see it as a money-making opportunity for them. And now it's mainstream. So I kind of feel like I'm owed some royalties for that, maybe down the road. I don't know. Anyways, I'm just happy that things have changed.
You've got tons of amazing good karma credit from it all, because I think it is really important to talk about this moment as well, because, there's a lot of things that you spend there about individualized care, and it really about that patient lived experience making the difference in creating this change. And it hurts my heart to say the 90s was 30 years ago, because that's when I graduated high school. But here we are. But also, like, what an amazing change to see as well over the 30 years. Ian and I often talk about, we're trying to create this grassroots army, and we're going to take anything and everything we have to get the information disseminated from the bottom up, meaning the patients are going to tell their doctors, and then take those clinical practice guidelines and know that we're also doing it this way to make sure that the docs and physicians know it. But it really is those lived patient experiences, I think, that have kind of cracked the surface, or help us crack some of this new ground as well, because it shouldn't be hard to get everybody to be on board that treating people in larger bodies as basic humans should just be a requirement, and not a thank you for going above and beyond the call of duty.
Yeah.
We should be, and I think we've made a great stride. We still have work to go. We shouldn't be robbed of these moments of dignity in the most, trying times as well. When we're in a hospital, I remember that was some of my first interactions and memories with you. It was in 2017 at the conference in Banff, and just really understanding, wow, somebody living with obesity goes to the hospital, and the only mode of transportation around the hospital is the one bariatric commode that they have. So that person has to be rolled around, and that is not okay. And the more people that we get going, whoa, that's not okay, whether I'm involved in every level of that person's care or not, these are the moments that are going to make a difference. And also, one other thing before I get off my soapbox, I also remember hearing you speak about, as you were saying, like, even toilets in hospitals that are wall mounted might not support people in larger bodies. Well, we can then talk to basic health and safety regulations and WCB or whatever those workers' comp bodies are, and say, this is a danger, this is a hazard. And that's how we're slowly going to make these differences as well. So I love all of those things that you said, and that really it's a moment for us to all recognize that, I might be referred to an OT or an RT, but it's still worth having all of these kinds of conversations, because they might be a different advocate than we ever thought that they could.
Absolutely. Absolutely, Lisa. And I think those were conversations that no one took seriously. And I think it was because obesity was hidden, right? It was hidden, or it was pushed away, or it was, people were not either showing up because they were so shamed and blamed, they were hiding, or so dismissed, they were invisible, even when
100%.
Right in front of us in the healthcare system. And I think it's really important to note too, that many hospitals and institutions are making changes. It's taken longer than it should, but it's starting to happen. Our next step is to push for accreditation standards that take bariatric care needs into consideration. I'm really excited too. I'm starting now to get people to ask me to sit on advisory boards for new hospital or long-term care builds, so that they're making these considerations in advance. And I'm hearing, architects and designers using person-first language, talking about bariatric friendly spaces. I'm like, oh my gosh, I don't need to be at this table anymore, which is lovely, sad and lovely at the same time. But it's that same feeling I had when the voices of people living with obesity were more elevated and respected in the research world, that I actually got fired from, and Lisa, I don't know if you were part of the group yet, but the Public Engagement Committee. Because I did, but it was a good thing, because I was no longer needed, because my job was really to bring that group to a certain point, and it took off, right? And Ian, I'm sure you remember those moments where somebody came and said, Mary, we have something really difficult to talk with you. Because I used to go to all the meetings and I was all excited about it. Says, you can't come here anymore, because I don't live with obesity. I wasn't part of that lived experience. And that was a joyous moment in just like not being able to have an impact from a research perspective, and it wasn't just me, there was teams of us doing this work, and then being able to step aside because it's self-propelling, and then we move on to the next challenge. So I think that's what research does too, creates change, has an impact, and then scientists don't need to be involved anymore. It's let the people who it's impacting and influencing move on and do the work that needs to be done, and let's go challenge the next problem. And I think that's a real important thing, is knowing when to step away from research as well, right? When to get your fingers out of the pocket, right? It doesn't need to be there anymore.
Yeah, I appreciate that point a lot. We do have a question here from Janice that I want to get to, but I think it ties into kind of what we had in here for our next kind of segment, what our next point here. So we've touched on some of these things a little bit, but I think we could dig in a little bit more. So for those that don't know, Obesity Canada's mission is to improve the lives of Canadians living with obesity through research, education, and advocacy. And so I was wondering, Mary, if you can maybe take us a bit through some of the research work that Obesity Canada has been involved in previously, and maybe what's some of the highlights of what Obesity Canada is working on currently. You're on mute.
Past and future?
Yeah.
Yeah. Well, I think some of the stuff that Obesity Canada has done really, I think, was instrumental, is bringing together. When it was first, the Canadian Obesity Network is bringing together diverse thoughts and opinions and skills. And, you know, some of the research led to things that some people here may have experienced, is the 5 A's on how to have a conversation about obesity in that clinical context, with respect and with dignity. And that seems like that was a long time ago that came out, but that came from research. That came from listening to various voices and experiences and bringing that forward. Now it's a standard of practice across many primary care centers and beyond. The other thing I think is just this spotlight on bringing attention to weight bias and stigma, and how that actually is the foundation of everything that we do. Because without addressing weight bias and stigma, we're not going to see research moving forward. We're not going to see quality care moving forward. We're not going to see advancements in employment and respect in all areas of life. So Obesity Canada really made sure that that was a pillar, and it was based on evidence. It was based on collaborative research that we did in Canada and the United States, drawing from expertise from our colleagues in the US who were a little ahead of us on that key. And I think we took lessons learned from them and put them in the Canadian context. Building capacity for research, the boot camps that you talked about, the research training schools that we've done. The other thing that Obesity Canada did early on was they got to the table, and we're still doing this. This is work we are still continuing to do, is we're getting to the table of tri-council funding agencies. And for those people who might not be familiar, those are the main federal pots of money that researchers apply for. And it's a very, very competitive process to be able to fund programs of research. So early on, this would have been just as I was finishing up my PhD, I think it was around 2009, 2010, I might be wrong on those dates, but we met a group of us with CAHR, and they brought me in as a trainee because of my expertise in rehab science. And we had scientists in mental health, in physiology around the table, meeting with the head scientific director of CHR, which is the Canadian Institute of Health Research. They have an institute for, I always mess this up, nutrition, diabetes, and metabolism. I think I might have flipped some words, sorry. But what ended up happening after that meeting was we identified priorities for obesity research that needs funding in order to continue. And we addressed physiology, learning more about the physiology of obesity, which would then translate into pharmacotherapy advancements, a better understanding of that brain-gut connection. We also prioritized health services research that would take a look at how can health services be more accessible safe and effective for people living with obesity. And then we were also taking a better look at what is that lived experience so that we can better understand what the individual personalized needs are for people. And that launched millions of dollars of funding earmarked for obesity research. And that was that kind of funding that launched the early careers of some key researchers that are well known, including Dr. Sue, who you've heard in these conversations as well, myself and others. And it's been fantastic. Where we're now, though, is a gap. We've had a little bit of a lull there. Could be lots of reasons, could be COVID, could be fatigue, could be competing, other competing priorities. But we are there with Obesity Canada advocating again to make sure that we have the funding to support the research that we need to be able to continue on with the work that we do. So that's the future, Ian, I think is advocating for funding for research to continue, but not just having research that sits on a shelf. Another real push that Obesity Canada is doing is we're really trying to get in front of policymakers and changers in our system, in our health system, in our research system, in our benefits packages, and all kinds of things, to take that research knowledge and then realize that into day-to-day reality so it benefits people living with obesity. And so that's really where I think we're heading with Obesity Canada, is advocating for research that's really focused and meaningful, but then making sure that gets into the hands of the users. And Ian, I know you and your group do a lot about that, is letting people know how to advocate. What is the science? What is up and coming? What do you need to be asking for, so that we can make sure that the money that comes from our government to support our research is put back to the taxpayers who are going to benefit from it. I think that's a really important feedback. And then we have industry partners that we're building relationships with to make sure that they realize the value of the research that's out there and that we can pay that forward as well. So we've got a number of partnerships with industries that include, insurance companies. I won't name anybody specifically, with pharmacotherapy, pharmaceutical companies. We are working on getting better partnerships with some of the rehab equipment manufacturers, like wheelchairs and hospital beds and designers. So really, the sky's the limit. We really are trying to target. And everything we're doing for the next 4 to 5 years is all targeted towards having a national obesity care framework, so that we are making sure that any other policies that are advancing other chronic diseases that might have obesity as part of that, diabetes, for example, is to make sure that Obesity Canada is at the table. So they are using the definition of obesity as a chronic disease, that we are making sure that they're measuring it correctly, that they're using the right metrics to evaluate it, and that it's getting back into the user groups that need to know about what's going on. So we're at the table with Diabetes Canada, Heart and Stroke Foundation, various rehabilitation companies. So our reach is getting much broader. We've done really great work at the medical side of things. I think we need to get out and broaden our scope, and that's what the future, I think, is going to be. I would say watch out for the next, year to 5 years, and we're going to spread our blanket a little broader.
Yeah, it's definitely an exciting time. It feels almost, from someone who's been hanging out in this space for the last little while, and especially as a patient advocate, and kind of Lisa and I building this community that we have, and all the stuff that we've gone over the last couple of years, it almost feels like we're on a bit of a tipping point, and there's been some things that have kind of built up to that. So, Obesity Canada, we once, we did it twice, but we did the report card on access to care as a bit of a research project. And what that did was it gave us an idea of, where and how and what the access is to those evidence-based treatment options. We know it's not great. So that gave us kind of that kind of baseline of information, knowing that access across Canada for treatments, for example, is not good. And there's certain spots in Canada where it's even worse. And so that gave us something to target and go, try and improve or advocate for. And then we went on and we've talked about it a lot. And a lot of this series has been about the clinical practice guidelines. So now we have this evidence-based, information that we can use as best practices. And so we have that research base of, this is what we need to do to treat and manage obesity based on what the evidence suggests. And the guidelines, we've talked about it before, they've been internationally renowned. They're being adapted in other countries, and it got a lot of attention. But I think the problem is, and where we are right now, is taking that information, the research and the stuff that we have in the guidelines, and putting it into practice. And I think that's where the implementation of those guidelines and that research into practice is kind of that tipping point that we're on right now. And so that's why everything that we're doing, like you mentioned, Mary, is kind of angled towards creating that national obesity care framework. So it is something that we are working on, and I think it's something that will happen. I think we'll have some really positive change that comes out of the next couple of years based on the work that's been going on and the work that's going to happen. So it's definitely an exciting time.
A lot of the work that we're doing as well, I think, would fall under the reference point I use, and I know I use a lot of idioms, is that cathedral thinking. So from Ken Follett books, like, you're building a building that you might not see the end result or understand every person that's going to cross the threshold. And I think that's something very interesting for all of us to kind of breathe and remember as well in these moments of tipping point, when it feels like, oh my gosh, there's still so much to do. But also, let's look behind us and remember that the 90s was a very different time, and we treated people in larger bodies like garbage. We still have a lot of opportunity, but I think I truly believe this, and it's not just because I'm this close to it. I'm seeing a difference, and part of that is that next generation of caregivers that have also been, steamed up in this environment where we are using different language. And one of the things that I love that Obesity Canada has given me, and what I'm trying to give back to everyone else as well, is a really solid common language to be able to just even talk about this. Because I come from a multi-generational family that has lived with obesity, but did we talk about it? Heck no, right? Like, so with that, I inherited, I always say, a lot of poor coping mechanisms, a lot of misbeliefs in my head. And I think the more that we can help each individual unpack some of that and let go of some of those balloons that they have been carrying around since they were little kids, we'll get that much energy back into Canada as a whole. People will show up for their lives. The obesity science world will benefit, but I truly believe the world in general is going to benefit from all of this work.
Oh, Lisa, you wrap everything up in this beautiful, I love that. And I was thinking as you were both talking, if I had 10 years ago or even 15 years ago, said, this is what you're going to be doing on May 31st, 2022. You're going to be sitting with Ian Patton and Lisa Schaefer, and you're going to be talking about science and research and obesity. I don't think anyone's going to show up and hear.
Who's going to come to that?
Yeah, here we are, right? So I think it's just so exciting. And we've got to get over when we hear science that it is nerdy. I'm nerdy. I love science, but it's not the beakers and the test tubes and the bubbling waters in a lab. That's part of it. But it's also what's happening in our everyday lives and the observations that we're making that can impact change. So how we collect data is so broad, and that's what obesity research is really all about. So.
Yeah. And as a creative person and a marketer, I always remind people the data also tells us what happens over our shoulder. The opportunity is how do we move it in a different direction or move it even further forward. So I love my researchers and I love my data. But really, it's the people and the passion that are going to move this train forward and in the right direction. Yeah. And with that, look at that. We gobbled up all. This felt like a blink of an eye. Thank you so much for joining us today, Mary. This was a delightful conversation, and I have a feeling we might even be asking you back again to talk even more about this national obesity framework. I think that's super important as well. I can't thank everybody who joined us here today enough. Please tell two friends who will tell two friends as well. We always like to share the wealth. And remember that there are ways that we want to continue these conversations. Please sign up for the newsletter if you haven't. If you're part of the patient community or supporting someone living with obesity, please join us in OC Connect, which is our online community. There's also OC Connect Pro, which will provide resources if you are a healthcare practitioner, a researcher, or someone working on that side of obesity management as well. So find us, talk to us. We want to continue these conversations. They're meaningful to us, and they definitely seem to be impacting change as well. So keep joining us. Thank you for everything. Take good care of yourselves. Be kind to yourself. Be kind to at least one other person, and remember to wash your hands, as always. Amazing. Thanks, everybody. Take good care.
Thanks.